Hello and welcome. Thank you for choosing this session. Very interesting one. And we have very nice presenters. I'm Siham Accacha from Northwell Health. I'm very honored to be chosen to be the moderator today for this very interesting topic. Transition, access, shared decision, and psychological support. And without any interruption, we are going to start. I'm going to present each presenter and with their, the topic. And we have about 10 minutes, and then we have like about 4 to 5 minutes for question and answer. If anybody has any question, please first tell your name and tell us from which center you are, and then ask your question. That would be great. So for our attendants that are on Zoom, they would know who you are. So our first speaker is Dr. Douthit from Children's Health Care of Atlanta, and she's going to present implementation of an electronic medical record pediatric to adult healthcare transition planning tool for youth with diabetes. Thank you.
Okay, I'll stay by the mic though. Yes. Okay. Let's practice this. Okay. So yeah, I'm Katherine Douthit. I'm a pediatric endocrinologist that practices locally at Children's Healthcare of Atlanta. And today I'm going to share a QI initiative that I worked on last year on improving the transition from pediatric to adult care process in our outpatient diabetes clinic. So first, why should we care about transition? Well, the transition from pediatric to adult care period, especially for our patients with diabetes, is a particularly vulnerable time. Not only during this time are they at risk for worsening glycemic control, but also increased risk for acute complications like ED visits for DKA, as well as this is when we start to see the emergence of chronic complications associated with poor diabetes control. So guidelines, let's see if this is going. I'll use the computer. So guidelines recommend early and structured transition planning, but in practice, this doesn't really happen consistently. I definitely thought that this was an issue that needed to be addressed at our clinic. And at our clinic, so we had just started implementing a kind of structured transition to adult care process, but didn't yet have any standardized way to document that process. So my first goal wasn't to tackle improving our transition process overall, but I felt that we needed to start with a structured documentation tool to allow for future QI initiatives to be, more easily trackable and how effective they were. So I have some background with the electronic medical record system and helped build a tool for providers to document their transition discussions. And then I used PDSA cycles to track how often providers were using the tool and tried to increase tool use with a goal of at least half of our patient visits for patients 17 years and older with diabetes having the tool completed. Over the course of a year was the goal. So again, this took place at Children's Healthcare of Atlanta at our outpatient diabetes clinic. It involved patients 17 years and older with diabetes. I first started collecting data at the end of 2023 for some baseline data before the tool was released, and then released the tool and had my intervention period from January to December of 2024. My primary outcome was the percent of established diabetes visits for patients at least 17 years and older, where providers had interacted with the tool at all. And then I used the EMR to track tool usage, which was its primary purpose, but also for clinical and demographic data collection. I used run charts to track my progress. I distributed surveys to gather feedback from providers based on both on how they felt about the tool, but also on feedback on barriers to use throughout the QI initiative. And then I used odds ratios to compare PDSA cycles and chi-squared analysis to look at how different patient characteristics were associated with whether or not providers use the tool. So hopefully you can kind of see this. I realize it's maybe small on the screen, but the tool itself was a smart form, which we placed in the part of the chart where providers spent the most time charting during their visits. And then later on, during the project, I added a smart text which linked the contents of the smart form directly into provider notes. And then we also added a scheduling track board reminder in clinic, which flagged patients that were eligible to have the provider start documenting transition planning. All right, so at baseline, before the tool was released, I found in free text that only about 1 in 5 visits for patients 17 years and older with diabetes did providers document discussing transition at all, which wasn't too surprising. I collected data from the patients of about 30 providers in clinic and looked at, in total, about 2,200 encounters for 1,100 unique patients throughout the year. Providers identified time constraints, unsurprisingly, as the main barrier to using the tool, but overall, the tool is pretty well received in terms of its usability. And then here's my run chart. So when the tool was first released in January, there was decent use of it. About 25% of visits were the providers using the tool. In February, I demonstrated the tool visually at a provider meeting and then distributed that satisfaction survey. In May, I revised the tool based on some feedback that I received from providers, adding some readiness assessment questions for them to, interact more with the tool and maybe guide the transition planning topics being discussed, and then demonstrated the tool again at a provider meeting, at a divisional meeting. And then August, I reminded providers again at a division meeting, but also distributed the survey on barriers to use and gathered additional feedback on how to improve how often people are using the tool. And then ultimately in November, I made the final revisions to the tool and added those reminders I showed earlier to the scheduling track board and pulling the tool into clinic notes based on provider feedback. So here is just odds ratios showing, comparing the PDSA cycles. So you can see that there was unfortunately a significant reduction in odds of tool completion from cycle 1 to cycle 2, and then a non-significant upward trend in tool use across the remaining cycles throughout the year. And then here is where I looked at how patient characteristics were associated with whether or not providers completed the tool. And unsurprisingly, I found that patients that were at least 20 years of age or older, and then patients that had at least 3 clinic visits throughout the course of the year were more likely to have the tool completed. I did find non-significant trend for the tool being less likely to be completed for non-English speaking patients, as well as our patients with atypical forms of diabetes. So this included all of our patients with diabetes, including, like MODY and CF-related diabetes. So ultimately, while I didn't reach my goal, I did create a structured documentation tool for planning transition discussions where none existed previously. And I think my findings support, at least at our center, the need for a dedicated role to guide the transition planning process to better support our patients with transitioning to adult care. Okay. And I'd like to thank Dr. Cosson, my mentor, who helped a lot throughout this.
Yeah.
Thank you so much for that talk. I have a twofold question. When you say smart form, how does that how does the user interface with that? Like, does it pop up? Do they have to go to a specific tab, or like, where is it in their Epic?
Sure. So it's on a tab called, it's on the this visit tab where the provider would be ordering medications. It's where we enter, when the patient's going to follow up next, all of our discharge instructions. So it's where the providers are spending most of their time, and we put it at the very top. And it only showed for patients that had a diagnosis of diabetes that were at least 17 years old.
And I couldn't read. Do you mind just saying what some of the key things in that smart form were? Because I couldn't see all of the
Sure.
things.
So
Thank you.
we kind of decided based on ADA guidelines as well as other national guidelines for just chronic diseases on some of the most important skills we thought patients would need before transitioning. So it says do you know where your pharmacy is, how to call and ask for refills? Do you know what to do when you're sick in terms of ketone management, when you have hypoglycemia? And then let me think, what else if they know their medications and their medication doses. So very basic things that we felt they needed to be able to do. Yes.
Oh, okay. Hi, Christy Caroli with Grady Health System. Since you said it was less likely to happen in patients that were seen less often, and one of the barriers was provider time, do you think this is something that could be done as part of pre-visit planning, maybe in chunks, just when you're calling for reminders or something similar?
Yeah, definitely. I think that could be a good time to gather some of the information about, if they've identified a provider, who it is, when they plan on transitioning, all of that stuff's at the top of the form. We had also just started this teaching program that our CDEs, our diabetes educators and social workers, were implementing on teaching, all the skills that patients need before transitioning. But we didn't have a process for documenting that. So that was part of this documentation tool as well.
Hello, thank you for your presentation. I'm Nana Jones, pediatric endocrinologist at Cincinnati Children's Hospital, and to my left is Andrew Welch, who is an adult endocrinologist at University of Cincinnati. So it's literally transitioning from me to him. So we have very robust tools for transitioning. We use the Ready 2.0 developed by Sarah Carruthers at University of Cincinnati Children's. And we use it patient-reported outcomes, so the patient's actually filling it out, and then it pops into our EHR. But Andrew and I still struggle to get the patients successfully transitioned. So do you have data on how many successful transitions you have with this tool? Because like I said, we have a pretty robust system and we still can't get them.
So that was my next goal with tool use, because another part of the feedback that I got from providers was they were like, so what? Why is this needed? But my hope was that if we gather where patients are transitioning to, we could, hire somebody that can help confirm that they are indeed, being seen by that adult care provider, and seeing if this transition planning education program that we're implementing is having like any effect. I also wanted to start implementing the readiness assessment survey. I got that, but we needed to start somewhere, and that was with documentation. But I'm not sure how successful we are right now, honestly.
Okay, and thank you. We have time for, unfortunately, only one more question. So Dawn has a question on Zoom.
Okay, thank you very much, Mary. We have a question from Jennifer Inger. She asks, aside from time constraints, any feedback from providers, maybe anecdotal, on what would make them more likely to use the form?
So I asked for like if they had a hard time locating it, if they didn't know what patients should have it completed for, if they thought it was important. So some of the feedback I got was that they just forgot, which is why I implemented some of the different reminders in the EMR. A few said that they weren't sure when they should be filling out the form. So that's that like banner at the top that is in red trying to explain, when it's appropriate to complete the form. Hopefully that helped. There weren't any other anecdotal feedback that I can remember.
Thank you. So next presenter, Mili Vakharia. She is from Texas Children's Hospital, Baylor College of Medicine, and she will be presenting Next Stop Adult Care, implementing a transition roadmap to youth with diabetes. Thank you, Mili.
Hello. Good morning, everybody. Can you hear me okay? All right. I'm excited to share with you some of the work that we've been doing at Texas Children's Hospital, Baylor College of Medicine. And you can see it took so many of us at Texas Children's. And just like our team, Texas Children's is also bigger. Kind of like in Texas, everything is bigger. We see over 3,000 patients in a given year with type 1 diabetes. With type 2 diabetes, it's close to 800. Out of this, in the last year at least, over 16 years old, we had about 1,000 patients that were seen. And then for type 2, it was close to 500 patients. 40% of them publicly insured. And you can see we have a large group of providers ranging from endocrinologists to nurse practitioners, PAs, diabetes educators, social work, and so forth. What I want to point out is that within the state of Texas, in Houston alone, we have 4 major hospitals, and 1 is in Austin, and then 6 satellite clinics. And the reason why I share that that data with you is because to kind of collaborate and coordinate such QI work is massive within, such a large institution. And the work that we do cannot be done just by one person alone. It really takes a village. So some of the background that I won't go so much into detail because Dr. Mary covered it very well and set the stage. But adolescent period and transitioning from PD to adult care, as we all know, is such a delicate and vulnerable period, where not only are they going through so many developmental physiological changes, but mentally, my goodness, PSATs, SATs, the pressure of applying for colleges, and just the peer pressure alone is so much for them to absorb. If that transition is poorly coordinated, we know that it leads to such a significant gap in care, and including decreased follow-ups, worsening glycemic control, as Dr. Mary pointed out. Not to mention this chart on the right is nicely illustrated by Dr. Sarah Carruthers and her colleagues who have done such an amazing job in the transitions world. But what that graph sort of highlights is that the time from the last PD endo appointment to the first adult endocrine appointment, if there is such a delay in that or a gap, then the A1C levels will continue to decline. As such, the ADA and the ISPAD guidelines really emphasize a planned transition process where we need a structured education and preparation to sort of have a therapeutic end from a PD to an adult relationship with the patient. So a year and a half ago, which is the duration of this project really, is we surveyed providers, about 31 providers. And what we wanted to first find out was what is the age of first discussion of the transition. And we can see that it was a little bit on the later end, which is close to 17 years of age. And a vast majority of the providers, yes, they felt comfortable doing the transition discussion, but what they were not comfortable with here, you see, is the discussions on alcohol, pregnancy, and expectations. So sex, drugs, rock and roll, sensitive topics. The key driver diagram here, the fishbone diagram here really kind of points towards the key drivers as to what's obstructing the transition planning at our institution, where we didn't have any formalized transition process or policies in place. The providers were not comfortable discussing those topics. As I mentioned, patients were sort of lost in the system, and that has been also validated through some of the focus group surveys and focus group discussions that were held with adult endo providers through our psychology group, along with our patients. And there was not a standardized way to document the education that we provide, and we didn't have any education materials to begin with. So a lot of work needed to be done. So we had this ambitious goal of developing a transitions roadmap and increasing the rate of older adolescents age 16 and up with a documented transition plan by 30% over a year and a half from a baseline of 20%. You can see a year and a half, right? So 2023 to June of 2025. And we employed a series of PDSA cycles to kind of make this work happen. The first thing that we did was in 2023, November, we implemented a transitions policy with a transition curriculum. So you can see that on the right side where the providers, the diabetes educators, the social workers, everybody sort of had a delineated task list as to what they were supposed to do, along with the time period. So starting at the age of 16 is when we initiate that transition discussion. So by the time our patients are 17, 18, 19, it's not such a rude awakening and such a surprise for them. On the bottom that you see is our provider doc flow sheet. That is what it's called in our Epic EMR. And we leverage this technology to sort of have a documented date of transfer, along with those key 4 sensitive topics that were identified. And so one of the other things that we needed to do is to have a very clear roadmap, whether it was a provider, endocrinology a specialist that's discussing the transition, or a diabetes educator. We needed to ensure that everybody was sort of on the same page and providing the same type of education. So on the bottom, you see a flowchart transition. So at the age of 15, 16 is when we start discussing driving education. And then 16, 17 is more of discussing pregnancy and alcohol and diabetes. And then once they are 17 to 18 years of age is when we are bringing up the insurance education discussion. So you can see this was a very streamlined, very structured education that we developed. Along with this, we held a transition seminar for over 100 of our staff and providers across the Houston area to increase their confidence and comfort in managing transitions. And then we also provided them with a list of adult endocrinology providers across the Houston area. And then on the bottom, you can see is our education materials, along with having that embedded into the clinic passport. So sorry, I think I just went backwards for some reason. Okay, there we go. So you can see the results were not surprising. With the fruit of our labor that we had is that we achieved our SMART aim from increasing the documented transition plan from a baseline of 20 to 50% for the same cohort of patients that I mentioned in my initial slides. And this was a significantly statistical centerline shift from a baseline of 49 to 65% by the summer of this year. And many, many thanks to Don Buckingham, who is in our audience today, for really giving us this graph and sort of highlighting the work that we are doing in a very visual format. In summary, the lessons that we learned along the way is the team-based care was really a roadmap to a successful transition, and we had to leverage our EMR integration, a multidisciplinary approach to transitions, and having a very clear distribution for the team members. In future, we do hope to sustain these improvements and sort of monitor patients' outcomes like post-transition, what Dr. Nana was referring to earlier, like what is that percentage of patients that actually do have that adult endocrinology appointment secured, and then if there's any barriers for publicly health insurance, and that's something that we want to look at as well. And I cannot do this alone. It takes a village, and I'm very grateful for the Texas Children's Diabetes and Endocrine Service. Dr. Sonabin, who's our division chief, and giving us the infrastructure and really the support from the leadership and for us to be able to do the work that we can. We have 5 different diabetes quality improvement team, and you can see the list of folks that are mentioned in the names. They all take part in leading these initiatives in one way or another. Mark Rittenhouse from our Epic and IS team to make that Epic integration and all of that sort of nicely flow through into our ClickView app so we can analyze the data. And then the T1D Exchange Collaborative, thank you so much for this incredible honor for me to be in front of you guys today and share our exciting work. Thank you.
And I see Dr. Golden has a question.
Thank you. So Lauren Golden from NYU on the adult side in New York. That was great. So I have 2 questions, if I may. One is it possible to use something like this as a passport among institutions, between the different institutions, with a question at the end that the adults would actually have to check off that the patient arrived? Because we've been doing it manually. Obviously, not all of our institutions are on Epic, but for example, at least for those who are, I'm actually just wondering, do we need to recreate this, or could you guys just have that final question and we could say, yes, they're here? So that's one question. We also have been struggling with folks with public, like some of the Medicaid plans, that pediatrics takes a lot of plans. The adults are told we can't take the same plans. And I don't think this is unique to us, but I'm wondering, can we leverage, is there some kind of economic conversation that we can start to have with our individual institutions about why we have to do this? I've not found, because it's the right thing to do, to be resonating in any particular way. And I think I at least need help at our site to leverage the economic reasons why we need to do this. That seems to be the only thing they're going to be listening to. So those are 2, some of that may be for the group, but I'm just wondering, with a passport like this specifically, could we hand it off?
Thank you, Dr. Lauren. So if I understand correctly, the first part of the question was, can we have the same thing replicated on the adult endo side into the Epic EMR, where once the patient does arrive from the PD end, then there's a checkbox that, okay, the patient has safely transitioned. Oh my gosh, that would be amazing. And that would make our data collection so much easier and just feasible and seamless. And then the second piece was, remind me again, sorry, the second piece. Yes, definitely. I think there's so many ways that we can do that. We can look at, I think that answer can probably be best given by Dr. Nana here. But some of the DKA rates, right? So we've seen what Dr. Carruthers has shown us, that when there is that large gap in care and the hospitalization rates, the A1C rates, the DKA rates sort of all, are going very negatively affected. So if we can showcase that data to the higher up powers to be, perhaps we can convince them. I think one of the biggest struggles that we have is we don't have very many accepting adult endo providers who take public health insurance. So that's been our biggest barrier. But with that adult endocrine provider list that I was mentioning that we give to all of our patients, we do try to find a adult endo who will accept Medicaid and Medicare populations.
So this, Nicole said we have to be quick. So this is for Nicole. So I think this conversation is great. So I think T1DX has almost like here a mandate to look at maybe health outcome complication rates for those that do not successfully transition compared to those who successfully transition, which would then like roll into an economic model that cost more, that cost the health system more when patients fail to transition. And then I think another mandate we have is to our EHRs to create some type of interportal so that we can seamlessly document when patients successfully transition and when they don't. Like not only when they did arrive, but when they actually did not arrive. That's for you, Nicole.
So it is a great question. I think, what we're documenting for transition is pretty bare bones right now. And so we're not asking those questions. We're not collecting that data. So, people have to be committed to being able to identify like what is the definition of success and like are we tracking it? It's kind of reminds me of like when we did depression screening, are we actually making the referral? Did the person go somewhere? Did they receive access to care? So I think we need to connect the dots. We have the capability of tracking and receiving that data, but you all have to be willing to ask the questions, track it, and share it with us. So, and this is a good just recognition of the transitions work group. If you care about these things, you can connect with the transitions work group so that you can be a part of this process of making the data available. I'm going to give this to Georgia since we're in her hometown, but we're going to have this as the last one.
Had a quick question. So, at Grady, we don't have restriction on who can come to our clinic. We care for uninsured patients as well, and we still struggle with transitioning kids from CHOA to Grady. I am just curious if anyone's collecting data on the young adults plan and what geographic plans to move might impact this. So I feel like we see a lot of patients who go in and out of care in this time because they've moved and then they're coming back. And that definitely impacts our insurance coverage and their ability to find that if it's public. So I just wanted to make a plug for maybe some more data on that side.
No. Was that a question to everyone, just as a suggestion, right? Great. So I would like to introduce now Dr. Waterman, who's going to present development of transition curriculum from patient-identified topics. Thank you.
Hello. Yes, I'm Lauren Waterman. I'm one of the pediatric endocrinologists out of the Barbara Davis Center in Colorado, and I'm really excited to be here with you guys today to share with you guys something that is near and dear to my heart, which is the development of our transition curriculum from our patient-identified topics. So I don't have anything to disclose today. I don't think I have to convince anybody here that emerging adults with type 1 diabetes struggle with glycemic control and transition readiness. We've already heard that from plenty of people today. But just as a little bit, this is a time of growing independence for these young adults. And unfortunately, diabetes self-care can often kind of fall down the priority list, especially as they start encountering new and exciting exposures and living separate from their support systems. So in addition to the basic self-care, they do require anticipatory guidance on a number of topics that can greatly impact their health and safety, particularly around alcohol and substance use, particularly around cannabis, as that is increasingly legalized across the United States, but also looking at the impact of sex on glycemic control and then contraception and pregnancy for people who can become pregnant. And then unfortunately, kind of in the current climate, there is an increasing need on talking about insurance and healthcare navigation, especially when people are not able to financially afford their supplies. And then independent living and meal planning, particularly those who are on governmental programs. But since this is also a population where it can sometimes just be hard to get them to announce their meals, comprehensive transition education can be difficult to achieve in routine clinical visits due to time limits. And while I know I could talk to young adults about these things for a long period of time, we do have over 1,000 patients that we see every year who are 18 years or older. And so this is something that we need to develop kind of on a more clinic-wide. And so in order to develop our transition curriculum, I first wanted to determine the discussion rates of patient-identified transition topics in our pediatric clinic through EHR note template notifications. And so this was kind of a two-pronged project. One was going to be looking at what the patients are identifying as things that they want to learn more about, and then what are the providers actually talking about with kind of minimal educational interventions from me. And so first, we wanted to look at the patient-identified topics, and we use this through our Learning About Your New Experiences assessments, or our links, kind of based off of our Panther program. And this was adapted from the READY 1.0, so the Readiness of Emerging Adults with Diabetes Diagnosed in Youth survey. And for those of you who maybe aren't as aware of it, it ranks patient confidence in a number of transition topics on their ability to navigate this independently, ranked on a scale of 1 of haven't thought about it to 5, yes, I can do this. And it looked at topics related to diabetes knowledge, health system navigation, insulin self-management, and health behaviors. Now, we had attempted to use the READY previous to me taking over as the transition head. But unfortunately, this was limited by, one, it was long, it was 44 items, so a lot of our patients weren't completing it all the way. Or you get a number of people who just say, yes, I can do this to all of this, and it doesn't actually work as a readiness tool. And so in order to try to improve this, we actually divided READY into 2 parts because we weren't using the actual score. This was more of a conversation starter. And part 1 was more of the basics of diabetes care. So do you know what your hemoglobin A1C is? Do you know how to determine your insulin doses? And part 2 are more of the kind of the higher level things like sex, substance use, healthcare navigation. And then each part has, the goal is to administer on a yearly basis from the age of 16 until they transition to adult care, which is generally around 22, 23 for our center. And since we started implementing Welcome, people actually can take this at check-in, so we don't have to worry about assigning it ahead of time or people just not taking the survey. But we also wanted to make sure that people actually, like the providers actually saw what the patients had indicated, since often it goes to the questionnaire folder and people may not have time to look at it for their clinics. So unfortunately, it might be a little bit hard to see this, but each question is assigned a keyword or phrase. So for this first one, it is describe 3 long-term problems that might come from a high hemoglobin A1C, gets turned into complications. Tell someone about the effect of alcohol on blood glucoses, gets turned into alcohol. We've got tobacco, and we have sex and pregnancy. And then topics that are not rated as, yes, I can do this, get included into the note template as a conversation prompt for providers. And so it gets put into the note in kind of prose form. So when the patient takes the links assessment, anything that's not written as a 5 gets popped up here. And then we were able to pull the patient responses from the last 12 months from the EHR. And the prompt gets put into the HPI, so it's very early for the providers to see. And then we also wanted to see kind of what topics providers were actually discussing. So we also included a drop-down list in the note template that prompted providers to document what they talked about during that visit. And it was a hard stop, so they must interact with it before they can close their note. And so even if they didn't maybe necessarily talk as much about it the first time, the goal would be with a number of repetitions, you would actually start to think about making sure that you talk about these topics early in your visit. And then we also pulled the discussed topics from the last 12 months from the EHR. And we've actually had some pretty good success about completion. So in terms of part 1, we had about 1,100 patients with 72% at least identifying at least one topic of concern. And then part 2, just because we also had to work around our DEPSAR and some of our other screenings, we had about 400 patients with about 83% identifying at least one topic of concern. And so taking a look at the graph, we have the percent of visits that the topic was either requested by the patient, which is in brown, or the discussed by the provider, which was in black. And the patients requested help across like most transition topics, particularly around insurance, sex and pregnancy, and tobacco. I don't know if I can, sex, alcohol, tobacco, but also diabetes goals, because these are mostly related to the hemoglobin A1C, which despite multiple discussions, it's still sometimes hard for people to keep that in their brain. But as you can see from the black, the provider discussions focused mostly on routine diabetes management with a little bit of diabetes goals. And the largest gaps kind of seen between substance use, sex, and insurance. And so despite the EHR prompts, providers still infrequently covered key components of emerging adult care. And likely this is due to, again, the need to cover many topics within a limited appointment time, but also a lack of familiarity with these topics by pediatric providers. But as I found in one of the other studies that we're doing, a lot of our patients are already engaging with things like alcohol, cannabis, and sexual activity. It is vital that we actually talk about these things early in our pediatric clinics. And so since I know it's one thing for me to say, oh, you need to talk about it, you need to talk about it, there are limited time periods. And so since we have a wonderful healthcare team, we thought it best to actually be able to utilize that. So we have been developing the Compass curriculum that goes along with our Compass Clinic. Since we're in Colorado, it's lots of hiking and mountaineering. And so we have our north, south, east, west when it comes to our transition topics. And our goal is that a number of different providers could cover each of these areas depending on time periods. And so we have our navigation, which is primarily focused on healthcare navigation that is kind of helped by our social workers and our patient navigators and some web providers. Education, which includes a diabetes refresher, but also substances and sex by the providers and the educators. Social support, especially in terms of accommodations and your rights, are through social workers and some patient navigators, and then wellness, which is a lot of our dietitians and our educators as well. Right now, we're piloting this within our monthly transition clinic, including a new Epic interface so that we can actually document when each of these topics has been covered at least the first time. And we're planning on widespread adoption into routine clinical care. Thanks.
My name is Candace Williams. I'm representing Cook Children's Medical Center in Fort Worth, Texas. You had mentioned about the hard stop for providers. So I take it you guys are all using standardized notes, so that is required. Okay.
Yes.
For some of these other, so this logo here, is this something that's available on paper for patients as well as in their EMR so that they're referencing it regularly?
Yeah, so right now we have the flyers that have the compass and all of these up in every clinic room because we're also growing the actual transition clinic. And so from a patient perspective, this is mostly this comes from an advertisement of the clinic itself. And then within the amongst the providers, there's a section built out in the rooming tab of Epic that will have kind of all of these topics available too. And then it helps do a running list of topics that have already been covered. So.
I did have one more question that, as you mentioned that, I did run into some difficulty kind of telling a parent, we're trying to start this conversation at 14, and so it was probably not ready, and told them what to expect. They were very resistant, not just to the, drug, sex, and rock and roll conversation, but just that, oh, well, we want to stay till we're 20. And I said, well, we're not going to do that, but, we'll walk you through this process. So how do you deal with, and this could apply for all the centers, families that we're having the conversation, but they're still very resistant to the information?
Yeah, no, it is definitely something that we have been having issues with because we don't have a hard stop in terms of how old people have to be before they transition, especially with Colorado. We do serve about a 7-state region. And so sometimes it is hard for them to even have an endocrinologist close to them if they're living up in Wyoming or Montana. And so we're a little bit more lenient on some of these things. But even just having the Ready questionnaire starting has anecdotally led to a lot more patients bringing it up themselves to the providers. That is actually a big feedback that I've gotten from my fellow providers is, oh yeah, people were actually asking about this. People were curious about this. And so we are starting our firm talks about it in Ready starting at 16, where people are feeling like a little bit more comfortable with the idea that college is coming. And so we haven't run into as much of a resistance about the general transition topic. Definitely there are some patients or some families that maybe don't want to talk as much about the alcohol. That's usually when I kick the family out of the room, or I keep it incredibly broad, like especially with cannabis being legal in Colorado at 21, it's like for alcohol and cannabis, you're totally not doing it right now, but do you know what alcohol will do? And that honestly has actually led to a lot of really good discussions, even with the parents who maybe are like, oh yeah, I hadn't thought about that. So.
I just have a question. Siham Accacha from Cohen Children. So with so many people involved in the care and, in this medical, how do you keep up who has done what and which part has been completed? Is there a way?
Yes, and that's what I've been working with our Epic analyst, which we are lucky enough to have a dedicated Epic person at our center who has helped me build all of these things. But the way that we have it structured within the rooming is we will be able to pull what patients have gotten what part of the curriculum as part of a report. And then having some of our patient navigators and the people who are part of the Compass curriculum, the eventual plan will be for them to kind of be keeping track. And then the same thing, making sure that we're having our educators and everyone else involved too. So if we know that they need to get part of the Compass curriculum, putting in a referral so that there is a note that they get seen at the next appointment. So.
Thanks a lot. So our next speaker is Rainey, and she's from T1D, exploring the emotional impact of clinical encounters among people living with type 1 diabetes. Claire, thank you.
All right, good morning, everyone. My name is Rainey. I work at Type 1 Diabetes Exchange, and I've been working there for a few months now, so I'm relatively new, but I've had diabetes for about 5 years now. And today I'm going to talk about the emotional impact of clinical encounters among people living with Type 1 diabetes. Before I dive in, I want to take a moment to acknowledge my audience. I know I'm speaking to clinicians who go above and beyond when it comes to empathy and connection. You all are a part of T1DX. You are at this conference right now, which is amazing. So my goal today is not to criticize, but to bring awareness to some of the negative experiences people with type 1 face, and then build on the great work that you're already doing, and think together about how we can make positive, supportive experiences the norm for everyone living with type 1. Okay, so some background to start off with. So we all know that type 1 misconceptions contribute to judgment and stigma that can affect people with type 1 diabetes across many aspects of their life. And these misconceptions are often seen in the media or among friends and family, but they also occur in clinical settings as well. So the aim of this study is to explore how communication in the clinical setting can influence people with type 1's behavior and the quality and frequency of the care that they receive. So this study explores the impact of judgmental or dismissive clinical interactions on their behavior and attitude regarding their care, how negative experiences can shape trust or mistrust in providers and future engagement with care, and the importance of clear, respectful, bidirectional communication in fostering person-centered care. The study employed a qualitative approach. We asked people from the T1D community, including people responding to the question of the day from the T1D Exchange, and we also asked T1DX staff members living with type 1 to share personal narratives and insights based on lived experience. So we gave them the following prompt. We're exploring how trust is built or broken between clinical staff and people with type 1, especially through communication. Often, trust erodes when staff speak or act from a place of judgment or assumption. We're gathering real experiences to better understand this dynamic. So we asked them kind of 3 primary questions. Have you experienced judgment or assumptions from clinical staff? How did you respond? And how did it affect your ability to stay open or engaged with them or that clinic? And I wanted to note that the clinical staff includes non-diabetes specialist care, endocrine care, primary care, frontline staff, check-in staff, staff who answer the phone, basically anyone who plays a role in your clinical experience from start to end. Okay, so 6 themes were identified across the stories shared, and we used inductive coding to analyze the stories. So these are the 6 themes we identified. The first is moral judgment and negative framing. The second is dismissal of lived experience, misinformed care, unprofessional interactions, emotional guarding, which refers to withholding and withdrawal, maybe some disengagement and loss of openness and trust between a patient and provider. And then inadequate support, meaning the patient is not receiving all of their needs met, they have unmet needs. Patients are left feeling isolated or unseen rather than empowered and understood. Okay, so I wanted to highlight a few of the stories that were shared. So I'm going to read them out loud just because we have time. But this is the first one. This person has been living with type 1 for 5 years. I had just made the switch from a pediatric endocrinologist to an adult endocrinologist, and it was my first appointment at the new clinic. I didn't know where I was supposed to go for the appointment, so I asked the front desk security person. I asked him where I needed to go for my appointment, for my diabetes appointment, and he said, "Diabetes? You have diabetes? You don't have diabetes. You don't eat a lot of junk." I was baffled by his response to my simple request of asking him for directions. I felt the need to tell him that type 1 is not caused by eating too much junk food. He gave me directions, and I walked to the waiting room, feeling sad and uncomfortable. This particular diabetes clinic is known throughout the world for their commitment to care and empowerment of patients. However, I felt belittled and judged in my first encounter there. So, to summarize, at this patient's first adult diabetes clinic visit, the speaker was met with a dismissive, judgmental comment from a front desk staff member, leaving her feel belittled and uncomfortable before even seeing her care team. This story is unique because the negative comment came from a security guard. It highlights that everyone in a clinical setting, no matter their role, plays a significant part of the patient experience, and what they truly say matters. Additionally, because this was the patient's first visit at the adult clinic, the encounter set the tone for all future appointments. Okay, next we have someone living with type 1 for 28 years. In a 20-minute OB/GYN appointment to discuss a GYN issue, the NPI spent the first half of the visit talking about my A1C. She said, "Your level is 6.2 now. It was 5.8 in your last visit. It's not moving in the right direction." I looked at her blankly and said, "You know that the standard of care goal is 7% and it's adjusted to 6.5 only for people when it is safe, and I am below both, right?" She reiterated that it was moving in the wrong direction and that this can be dangerous over time. I felt the need to mention my time in range, but also felt panicked, knowing that there would not be enough time to talk about the GYN topic that I was visiting for in the first place. As a person who has been hospitalized 20 times for severe hypoglycemia, keeping A1C below 7% has never been a recommendation of my endocrinologist. Instead, he supports me in trying to keep my time in range below 70, or keep my time in range below 70, below 4%. I felt angry and resentful that she was not giving me space for the important topic for the visit and was instead focusing on something that she had no history with and no expertise with. I think this story highlights some important themes of there not being enough time in healthcare for conversations regarding topics that are important to the patient. And obviously in this story, this patient came in to discuss the GYN topic, and there was no time left to discuss that because the provider was focusing on her A1C that she did not have expertise with. Also, I think it's important to address that not everyone is in a position or has the knowledge to challenge or correct misinformed comments from outside providers. And this particular person did, very knowledgeable with type 1 diabetes, but if other people receive these comments, they might not know what to do. They might take these as the truth, and they might start to spiral about their diabetes care. Okay, lastly, this person living with type 1 for 12 years. My provider at the time would pull up my pump and CGM reports and ask what I was doing at a specific time before a spike or before going low, etc. When I answered honestly, she would often clarify what I was saying with a furrowed brow as if in disbelief. And to be fair, I was 22, so I was doing questionable things and was probably too honest about that with her, but I felt really judged. At one point, she had me schedule an appointment with their social worker, which meant I had to pay a copay and take a half day off work at a time in my life when I was living paycheck to paycheck. After a brief conversation with the social worker, she was like, "Yep, sounds like you're 22. I'm not worried." At my appointment with the provider, I told her about the social worker. She seemed irritated. I was never honest with her again and answered all of her questions with as few words as possible. Later, I participated in a clinical trial at a different institution for a SGLT2 inhibitor, and during the trial, my A1C level was 5.4 at my regular endocrinology visit. After the trial was over, during my next visit with the provider, I had an A1C somewhere in the low sixes, which was still lower than my usual A1C. She furrowed her brow and said, "Are you sure you're not taking the SGLT2 still?" And I said, "No, the trial is over." And she said, "But you could still be getting it." I was so shocked that she was insinuating that getting an SGLT2 inhibitor under the table and lying about it. After that, I never went back or told them I was switching hospitals. I just stopped responding to them. So in this story, the speaker describes feeling repeatedly judged and disbelieved by their provider, whose skepticism and inappropriate referrals eroded trust to the point that the patient stopped being honest and eventually left the practice without notice. This story demonstrates a complete loss of trust. There is nothing left. I want you to think about privilege and socioeconomic status. This patient might have had the means or did have the means to transfer to a different provider, but what if she didn't? She might have been lost to care for years and never got the follow-up that she needed. Also, I want to note that the provider might not know exactly why the patient left the practice. The provider could think, "Oh, we just lost her to follow up," when in reality, it was the provider's comments that deterred the patient from ever coming to the practice again. Okay, so these are my results. The frequency of identified themes across patient participant responses. So I have my themes listed on the left, and then my theme descriptions, and then the total number of times that they showed up across stories that were shared. So you can see that the most common themes were moral judgment and negative framing and misinformed care, and then emotional guarding, inadequate support are at the bottom, but still very common, and the total N was 53. Okay, so key takeaways. Every interaction matters. Even brief or subtle comments can leave lasting emotional impact. Clinicians and clinic staff hold immense power to shape how people feel about themselves and their care. And these encounters are more common and more harmful than many realize. Awareness is the first step toward change. I'm sure maybe some of you were shocked by these stories, but they do happen more than you would think, and we need to be aware that this is happening. People with type 1 face so many frustrations beyond the clinic, including insurance, cost, stigma. So compassionate and empathetic care can really make a difference and help lighten that burden. So how can you make a difference? Regardless of specialty or role, basic human decency and respect builds trust. Your empathy and respect ripple outward, influencing staff, trainees, and other providers. So that goes back to the story with the security guard. these people can be highly influenced by how you are treating your patients. So it's important that you're doing that well and serving as a role model. Lead with active listening, empathy, and respect. Celebrate progress, validate emotions, and model compassion across your team. Aim for every person to leave your clinic feeling heard, safe, and respected. And be mindful of bias and stigma when interviewing candidates to really help create a positive and welcoming work environment and positive environment for your patients. Okay, that's all. Thank you.
Set up shop over here.
Claire, thank you so much. That was amazing. My name is Marissa. I'm with Children with Diabetes and Cincinnati Children's. And I think where I continue to struggle is as a person with diabetes as my primary hat, right, if you will, and as a nurse and a diabetes educator as my other hat, secondary though. How do we address this in every aspect of our lives? Because even at this conference, we are all here, we are all engaged, and still some of the language that has been used in presentations this morning has been suboptimal. And I'm just wondering if you've found, like what are the ways that you've found most successful in calling people in and having conversations about the way that they're talking to people without making them feel bad? Because I don't want to make people feel bad. I want to help them move forward.
Thank you for your question. I think that's a really important one. I've experienced kind of like harmful language even among my close friends and family, like people who really care about me. And I know it's not intentional. They're not trying to hurt me. But I think like media and all these stereotypes have it ingrained that we are not using like person first language. It can be very problematic. So I think, as you were saying, like calling people in rather than calling people out, really having just respectful conversations with people, saying, I know you did not mean to hurt me, but it ended up really, hurting me, and this is what you can say instead, and giving people alternatives. And I know it can take a while to create that pattern of using more appropriate language and person first language, but as long as you keep reminding people and you're not, I know it's sometimes scary to speak up like that, but just kind of surrounding yourself with those supportive people and not being afraid to call them in and educate them rather than make them feel bad about what they said.
Presentation, Claire.
Thank you.
I just wanted to chime in that I'm Alyssa Cabrera at the T1D Exchange as well, and part of the People with Diabetes advisory group, kind of involved with that group. And that group is actually putting together some really nice resources with talking points for how to talk to providers, which I know it's awkward, like you're talking up to someone that, has a medical degree, and how you can talk to them gently about some of the language they use, because it can be really awkward. So we've been thinking about like how to best do that, and Claire's been a part of that, and it's been a great project. So coming soon. Oh.
We all have slightly different takes, but I'll make one more plug. So Alyssa and Claire are also supporting the publications committee, and we do have a language guide. It's very brief. It's just 2 pages. Some of you have reviewed, contributed to it, so thank you. I will say, I have a job of sometimes editing some content. So like I've reviewed all of the abstracts for Journal of Diabetes. I will tell you, I go through that and I do a Control F for the word control. That's like the first thing that I do. And I spend time and I use better language. So, Marissa, it's not like, that's not the best solution, because I'm not even asking you, like you as the first author, like I didn't even bother to like knock on your door to say, hey, the reason why we don't use the word control is there are over 50 factors that impact blood glucose every day. And we can talk about what those things are and like hormone changes and being sick and not getting any sleep or, 45 other things. So we don't use that word because it's really triggering. And also like, we just don't have the control in our lives. That's just one word. There are a bunch of others and I kind of cringe when I hear them. I do think it's a pattern. Like I was using the word control 8 years ago, and then I met Jane Dickinson and I read her paper and she helped me to understand how it impacts us. And, I remember we have like small groups who talk about these things, and somebody with diabetes said, well, I don't care, like as a person with diabetes, I don't care if you call me diabetic. It doesn't matter to me. But actually, if you keep using that language, even though you think it doesn't impact you, it really does. So keeping our humanness first is really important. So us being intentional in our language use, we can help each other. It is a process. It doesn't like that. It's taken me, I think, at least 5 years to remove control from my vocabulary for diabetes descriptions. So we'll help you. I don't want to do control F forever. I'd like to bring you along with us in this thinking about language guidance. So don't feel like you're being judged for if we're kind of marking up papers, but we do want to use our intention is person first language in this. So thank you. And thank you, Claire, for presenting. That's it. That's a great point. Yeah. Yeah.
Hi. Thank you for your talk. I'm Tina Davis. I'm here in Atlanta at Kaiser Permanente, Georgia. I work in the research in the Center for Research and Evaluation. So thank you for bringing the voice into the room. So I really, really appreciate hearing people's experiences. I'm curious too, when you talked about people shifting to a new practice, right? And not telling, I'm wondering if anybody talked about doing multiple shifts, right? Or if they just kind of say, well, I tried one, I'll suck it up, right? Like I'm curious about multiple hops to different providers, if people talked about that.
Yeah, no one that I interviewed for this talked about multiple hops to different providers. But I imagine if people have the means to do that, that would be a very feasible scenario. Yeah, so yeah, no multiple hops, but again, it is a matter of cost and location. There's so many factors that go into that.
And
So
I'll just pipe on. We'll pipe in on this too. So like we talked about regionality, like obviously if you're living in a state where there is not another endocrinologist in 100 miles, it's a very different experience. But if you live in a dense city, it is not helpful to transition 6 times in 2 years. Like that's not a good experience. It's not good care. So we want to prevent those and not have people transitioning. And I would love it if people with diabetes would speak up and not just kind of quietly close the door on their practices, but to give feedback. Like it doesn't help you as practitioners to not know that somebody had a bad experience.
Right? Like, do you have that? So, I don't know. I hate the patient stuff.
That's a great point. Thank you.
That's a great point from Tina. I wanted to piggyback off of that because I think I'm also someone who lives with type 1, but find myself in a lot of deep and sometimes awkward conversations in a clinic visit, and probably don't have the right words at least 50% of the time. But I think I want to ask about how to be careful with things like Nicole is bringing up about using the word control, because I do think there is a time and place and a way to use those words where we shouldn't be fearful of asking someone to comment on that. I think they're part of the language that people are going to encounter, but having maybe the right type of discussion using that or involving, the person that's sitting in front of you to use that in a positive way? Can we reframe that? I think there's a lot of avoidance of language, but maybe it's also helping people use it in a better way. I don't know, because I think if we start also just not talking about some of the things we do have control or want control over, I know it's a different context, but I also don't want providers to be told, these are a list of things that we can't say. Well, correct, in the right context, they should be avoided. But I think it's about engaging the right conversation, and I think it's going to take a lot more effort and education, at least. Maybe it's not working, but I also need help in a more comprehensive way than we. So hoping that we're going to be working on that still.
So I want to just comment. I know Alyssa said it earlier, but I'm a co-chair of the PWD committee, and I think that's our main focus right now is not only giving patient the words, but also providing education for other providers around. I've had type 1, now my daughter has type 1, and I do have to say, I gave my daughter, I said, no one knows what diabetes is. Like, I gave her that knowledge early on that other parents don't know to give their kid and themselves, and they're shocked. So I think like some of the handouts and things we need to prepare for people are what to expect, what's out there, what words you can use if you do feel like you want to educate, because some people might not want to, and they might just want to know this is normal, people don't understand, and I don't feel like educating today. And then also education materials for providers, not only in diabetes world, but all around. So we would love input, whether it's wording or whatever it may be. Feel free to contact Emily or myself, and we would love feedback on everything we're making right now, because I do think that is a big focus. And I see other groups beyond type 1 is doing a lot of stuff. Like there's a lot that's we're trying to change this type of experience that people are having. So that's all.
And
there it is. Thank you. This is actually not a Zoom question. It's a Don comment. But what I want to suggest is this, is we're also doing quality improvement. And this conversation is really good for those of us that are practicing that science. And oftentimes there's a big difference between us trying to control a process and manage a process. And we use the word process control charts. Do you remember that phrase? That grows out of industry where you're comparing the use of physical items and you have greater opportunities to control. Really, we're doing process management. And so it's not as if you can't say control. This is not policing language as much as it's thinking what real accurately describes what it is we're engaged in together. And so oftentimes in quality work, I use the word management rather than control. I'm not sure how transferable that is to clinical work, but I'll offer it up anyway. Thank you.
Okay. Does this working?
Yes.
Oh, okay. Hi. I'm Laurel Kester. I'm from the Helmsley Charitable Trust. And for this has been an amazing discussion. I really feel very lucky to have been able to soak everything in. I have so many thoughts and ideas, but in relation to this conversation that we're having right now on language, I mean, we've talked a lot, I guess. I'm wondering from the community's point of view, we've talked about, onus being put on the person with diabetes, on providers, but I've also heard, what about the high level drivers? Like ICD-10 codes were mentioned. So how do you change the language of ICD-10 codes or diabetes journals? I think I would welcome conversation on, I think there's a role at kind of every level, but also in my work at Helmsley, not only around T1D exchange, but I think a lot about like what to do at the health system level to kind of top down, and there are, of course, like approaches from bottom up. But if there is a, mechanism to change the language that is being used by everyone, like ICD-10 codes, another area that we're working in is measures with NCQA. They have changed at least one of their diabetes-related measures, I think, thanks to some of our being able to work with them to glycemic management. So I guess it's not a question. Well, it's a question and comment, and appreciate the discussion.
Yeah, I definitely agree with what you're saying. I think like a top-down approach is definitely needed, rather than a bottom-up approach. We can't put all of the responsibility on the patient. I think what I have to say is like a lot of this language can start from kind of education when we're younger. I know, at least in my school, there was no type 1 education and there was barely any type 2. So when I was diagnosed, I had no idea what was happening to me. But I think even that, just educating young kids to grow up or to adopt more inclusive and appropriate language surrounding type 1 and other conditions can really help. I don't know if I can speak to like the ICD-10 codes, but Nicole will take over.
Yeah. So Laurel, thank you for your comments. I would say changing the systems would be excellent. And I've noticed, if you submitted a paper to like the ADA 6-7 years ago, you got away with using the word control. But if for those of you who have gotten papers back over the last 2 or 3 years, they will call you out now. So reviewers will say use person first language. And I was so excited to see that because I was I was trying to change it at the local level, but not realizing that other people on the other side would be doing it. So I think the ADA is there now, which is excellent. I don't know. Dr. Golden, I appreciate your point of the ICD-10. I don't know how to penetrate ICD-10, but I would love for us to at least, advocate and talk to them. So I think we can set up a meeting and make that request. I think it's totally reasonable. And if NCQA is moving in that direction, we have a precedent. So thank you. I think do we have one more? Yeah.
I'll be brief. This is Mary Scott with Endocrine Peds Endo at UAB. And I've lived with type 1 for 36 odd years, but and having taken care of both kids, I like to remind the audience, who I think you guys all know, but it's easy for people with type 1 to deflect those kind of comments by saying, no, that's type 2 diabetes. But in reality, especially the pediatric endos out here, we know that type 2 diabetes is not entirely caused by what you eat and your lifestyle, that so much more of it is genetic and epigenetic and environmental, that we need to encourage people to be mindful of that. 2, I've brought this up at a couple conferences, but I love Abbott's commercial about it's like microaggressions. If you just Google the Abbott commercial about even microaggressions that might pop up, but it's 1.5 minutes. It's great to show other providers, trainees. It's a guy who's basically walking around, and every time somebody says something about his diabetes, a new post-it attaches to him. And it's about all the crap you hear from people all day long about, are you supposed to be eating that? What are you doing? And I think that's helpful. And then 3rd, I have advocated for this for the longest time ever, but can we please stop allowing patients and as providers using the word brittle, because it makes me really angry. It's not a different kind of diabetes. It is diabetes with a lot of swings. And people need to understand, because a lot of patients take it as a sicker label and they like it, which I dislike about that label. Or providers have told them they're brittle, which then is giving it a judgment. And so, but that's my least favorite word of all. And if someone would never say it again, that would make me very happy. So. And also everybody on the ICD-10 committee, from what I heard, most of them were surgeons and there were no endocrinologists on that committee.
I just want to thank everyone. Thank you.